this as part of the registration. So thank you all for your interest. Thank you for not being too shy to call yourself a dummy, which I have to admit makes me feel a little bit bad, because by virtue of being on this webinar, you're clearly brilliant if you know what HIPAA is and care enough about it. But we've found over the years at EHI, the eHealth initiative, that HIPAA is a pretty misunderstood law and set of regulations. So we had a webinar on this topic about a year ago that was apparently pretty helpful. And so we're going to do a reboot of it. And I'm really excited to have all of you here with us. I am Alice Leiter. I am a healthcare regulatory lawyer by training with a specialty in health information privacy. I've been at EHI for almost 2 years now, working on health privacy issues. And although I am a lawyer, I want to make very clear that I am not your lawyer and that nothing in this webinar should be construed as legal advice. Some of the questions we received were pretty specific, which is terrific. And I really did my best to organize the presentation in such a way that it covers as much as possible. But there are certainly some specific questions that came in that I wasn't able to hit in the interest of getting through a lot of really complicated and a broad array of information in an hour. So if I don't answer your question or I didn't answer your question, you should feel free to email me. You should feel free to put your questions in the Q&A box. And if we have time at the end of the presentation, I'll do my best to do a speed round. I always like to start by explaining that HIPAA is spelled HIPAA. It gets autocorrected to HIPPO a lot, which I enjoy. And it stands for the Health Insurance Portability and Accountability Act. It, as you probably know, is the primary federal law that protects health information, and it governs uses and disclosures of that information. But specifically, it covers health information that identifies the subject of the information. It also only applies to certain people and entities. It only covers information that is created, received, or maintained by or on behalf of healthcare providers and health plans, and also healthcare clearinghouses, which is the third category of covered entities. And even though it's often thought of as a restricted law or cited as a reason that people can't do things, it's actually a pretty permissive law. It's designed for the purpose of sharing health information in a privacy protective way. I also wanted to note that, as with all federal laws, HIPAA is a floor when it comes to protections. There are as many state laws governing health information and health privacy as there are states. And I feel sorry for any of you who are associates at law firms, because I know what those 50 state surveys are like. But often state laws are more restrictive than HIPAA, particularly when it comes to categories of sensitive health information, like mental health information or substance abuse information. And so if a state law is more restrictive, it governs. HIPAA is a trusty workhorse, and it's doing its best, but it's getting up there long in the tooth, as one would say, in age. It was passed in 1996. At the time, it was a big deal. It was going to improve the efficiency and the effectiveness of the healthcare system, which was increasingly dealing in digital health information and digital health systems. And in addition to being focused on privacy and information sharing, it required the creation of national standards to protect that sensitive patient information from being disclosed. And importantly, the protections are supposed to apply to those circumstances that the patient may not know about or may not have consented to. Most often when we refer to HIPAA, what we're really talking about, especially in the healthcare provider setting, we're talking about the privacy rule. And the privacy rule applies, importantly, to providers, doctors, hospitals, health plans or health insurers, and healthcare clearinghouses, which I think, and I don't mean to betray my young age here, but I think we're more relevant to HIPAA in '96 when this was passed. But healthcare clearinghouses are entities that process or facilitate the processing of non-standard data elements of health information into standard data elements. Again, usually for purposes of HIPAA discussions, we're really talking about providers and health plans. And the privacy rule, the HIPAA regulations also apply to contractors of these covered entities, and those are known as business associates, which I'll talk a little bit more about later. And the privacy rule sets the limits and places conditions on the uses and disclosures of protected health information, referred to as PHI, without patient authorization. So when a patient authorizes the use or disclosure of information, pretty much anything goes. And so the privacy law is designed for circumstances under which the patient has not provided that authorization. It also gives patients a number of rights with respect to their health information, and those include the right of access, to examine their health record, to make corrections in their health record, and that patient right of access is something, again, that has been tweaked or revised and expanded in recent years with recent regulations, which I will cover as we get toward the end of the presentation. The security rule is another one of the HIPAA regulations. This is the rule that establishes a national set of security standards for health information. And this security rule really applies to the technology used for health information. The privacy rule more applies to the people and entities that are holding it. As part of the HITECH Act, the Stimulus Act in 2009, the enforcement rule came out, and this strengthens the civil and criminal enforcement of the HIPAA regulations. It significantly increased the civil monetary penalties for violations of HIPAA, and made the Office of Civil Rights at HHS, or OCR, a pretty big deal, given the heft and strength and increased monetary liability for HIPAA violations since 2009. And then there's the breach notification rule. Unfortunately, we hear all too regularly about breaches of health information. And the breach notification rule requires HIPAA covered entities and their business associates to provide notification following a breach of unsecured PHI. This is also a really fun thing to do as an associate at a law firm, because who needs to be notified and when and under what circumstances is complicated. And I will not pretend to know that off the top of my head, but there's some good stuff in the breach notification rule regarding the particulars of notification. And I did want to note, because this was a question that came up a lot in advance of this webinar, as what is a breach? It's defined as the acquisition, access, use, or disclosure of PHI in a manner not permitted by the privacy rule, which compromises the security or privacy of the PHI. I think perhaps more important than what the privacy rule does cover is who it doesn't cover, but we'll start with what it does cover. Again, for the 800th time, covered entities, healthcare providers, healthcare plans, healthcare clearinghouses. Those are covered entities under HIPAA. And it applies to a particular kind of health information, individually identifiable health information that is held or transmitted by a covered entity or its business associate in any form or media, whether electronic, paper, or oral. And individually identifiable is defined, and it's defined very broadly. So it's not just a patient's name. There are a number of different identifiers that can render health information PHI. And then the privacy rule also applies to business associates. As I said, these are these contractors of covered entities. And they're not just any contractor, they're contractors that perform services for the covered entity that involves the handling of PHI on that covered entity's behalf. If you are a contractor of a healthcare provider or a healthcare plan and you don't handle, or you couldn't possibly be exposed to PHI, it's likely that you will not need a business associate agreement. All right, a lot of my work at EHI is focused on what the privacy rule doesn't cover. And so I think it's important to make clear that data created or held by a person or a company that is not a covered entity, so not a doctor, not a provider, not a healthcare clearinghouse, not a business associate, is not covered by HIPAA. Also, data that is not individually identifiable does not constitute PHI, and therefore it is not covered by HIPAA. And there are a lot of questions that came in. There's a lot of confusion in the world about what constitutes de-identified data. Under HIPAA, there are two ways that data can be certified as being de-identified. One is by an expert determination, and there's some specifics of what does that constitute. And you can also comply with the HIPAA safe harbor, which involves the removal of 18 types of identifiers. As I said, very broadly defined. To really beat this horse into its own death, data that an individual, that you or I generates, is not covered by HIPAA, unless at some point we give it to our doctor or our health plan. And then by virtue of being held by a covered entity, it becomes HIPAA covered data. But while that might seem simple, increasingly we have data on our computer, our phone, our ovulation tracking apps, nutrition apps, fitness trackers, or even order history on Amazon or any other website. All of that information very well may be health information. It might be sensitive to you. It might be identifiable to you, but it is not covered by HIPAA because I am not a HIPAA covered entity. And again, by extension, it's important to note that most health apps or health tech companies are not HIPAA covered entities in their own right. Sometimes they may be business associates of HIPAA if they've entered into one of these business associate agreements, but the most simplest way of thinking about it is that all of those trackers, all of those apps, all of those web browsers and tech tools that I talked about, they're not HIPAA covered entities. And again, therefore, even if they're part of your healthcare management, nutrition, health program, fitness program, the data that you upload or enter or is tracked by those apps is not subject to HIPAA and therefore not protected by HIPAA. I also wanted to note that most employers are not HIPAA covered entities, even if they provide healthcare coverage. If they're providing healthcare coverage, all the HIPAA responsibilities lie with that health coverage provider, the health insurer. But employers are not subject to HIPAA. And there are a lot of questions about what can I share of my employees? What can my manager know about my employees? Those are company policies. Those are not HIPAA policies. But again, to just really drive this home, once you take data from your provider, once you take data from your health insurer, or once your provider or health insurer transmits data to a third party at your request, it is no longer covered by HIPAA. And that's either because it was sent for a required purpose, a legally required purpose, because it was sent for a permitted purpose, or because you authorized it specifically. But HIPAA has walls, has boundaries, and data frequently starts out with HIPAA protections and then loses them as it moves throughout our increasingly broad health ecosystem. A little bit about business associates, because business associates are sort of the broadest category of HIPAA coverage. Typically, the sorts of things that a business associate would do on behalf of a covered entity would be something like claims processing or data analysis, utilization review, or hired for billing purposes. Those are the sorts of things that when you think, well, what is a business associate and why would I be one? Those are the sort of most typical business associate functions. And the business associate agreements are very specific. When a covered entity enters into an agreement with a contractor to perform services on its behalf that involve the handling of this very sensitive PHI, and again, not even just handling a PHI, but perhaps even potential exposure in the computer systems or course of business, the privacy rule requires that they enter into a business associate agreement. And what is in a business associate agreement is very specific and very important, because there are a number of different categories, there are a number of different things that you have to hit. It's a precise, a precise specification of how and under what circumstances the business associate will or will not use covered entity data. And the reason this is so important is because by virtue of the privacy rule, business associates are subject to all of the same requirements and obligations of the privacy rule, just as their covered entity partner. All right, so what can you do under the privacy rule? In general, under the privacy rule, there is a prohibition of using or disclosing PHI, protected health information, unless either the privacy rule permits or requires the use or disclosure, or the individual who's the subject of the information, or an individual's authorized personal representative authorizes that use or disclosure in writing. Again, lots of questions about what sorts of things can be done verbally, what sorts of things must be done in writing. Patients and their representatives can verbally request copies of their own health information, or they can request that their health information be given to their mother or caregiver. But when it comes to not an individual access request, but a disclosure, those requests must be in writing. The big three categories under what is permitted under the privacy rule without authorization is commonly referred to by us nerds as TPO, treatment, payment, and healthcare operations. Treatment is pretty self-explanatory: provision of care, coordination of care, management, when your doctors talk to each other, when a patient is being referred from one provider to another. Those are uses of your health information that do not require your authorization. Payment. All this is most relevant to the health insurers, payment, reimbursement, premiums, coverage and eligibility determinations. And then the broadest and sort of most interesting category of TPO, of disclosures that can be made without authorization, are healthcare operations. And there's been a lot of discussion in recent years and a lot of attention given the HIPAA notice of proposed rulemaking that came out in December, which I will get to, as what is healthcare operations? Is it too broad? Should it be expanded more broadly, this definition of what falls under this? Certain administrative functions, quality improvement functions that a covered entity does as part of routine business, or that are necessary to run its business, support, treatment, payment, all of that stuff, that constitutes healthcare operations. Again, it's defined under HIPAA, but it's pretty broad. It's everything from an evaluation of your staff to care coordination. So as you can imagine, a lot of disclosures fall under the O part of the TPO category. And then I won't read all of these, but there are a number of other enumerated permitted disclosures under HIPAA that do not require, patient authorization. And that's everything from something that's legally required, like law enforcement purposes, public health activities, which have been quite relevant in the last year under COVID, often in cases of abuse, abuse or domestic violence, workers' comp. There are, again, a long list of specific activities under the privacy rule. All right, probably more interesting to you all than all of this stuff, which you may already have known. There have been a number of changes to the sort of privacy landscape in recent years, exciting to all of us lawyers. Last summer, there were changes to what are known as the Part 2 regulations that were finalized. Part 2 is called Part 2 because it appears in the Code of Federal Regulations as 42 CFR Part 2, the confidentiality of substance use disorder patient records. And these changes last summer were designed to support better care coordination and beef up the privacy of this very sensitive information. And then as part of the CARES Act, also in 2020, Congress included legislation to better align Part 2 in its updated state with HIPAA so that there are no contradictions or issues with the alignment of these two rules, especially when it comes to the TPO functions I talked about. Rulemaking to enact those CARES Act changes are expected pretty soon. I will talk more about the CMS and ONC interoperability and information blocking rules in a minute, but those are the sort of belle of the ball right now, the big regulations that came out recently, but really have been in a 1996 is not when the 21st Century CARES Act came out. Apologies for my typo. But they implement provisions of the CARES Act, which came out a while ago, and yet it took until March of 2020 for those final rules to be released, and they just recently became effective, or I should say that the bulk of the regulations became effective just last month. They were supposed to be effective earlier, but they were delayed. The effective date was delayed due to COVID. And then in December, we got our first big proposed changes to HIPAA in quite some time. Very exciting. In December of 2020, at the very end of the Trump administration, the HIPAA NPRM came out. The comment period closed in early May, and all of us are waiting with bated breath to see if and how those changes are finalized. All right, ONC Final Rule. This is, I want to say, the ONC and CMS rules came out together. They are often referred to as the information blocking rules. It's the ONC rule that when we're talking about information blocking and patient access is probably the one that is talked about the most. Its rule requirements focus really on two things. One, HIT, Health Information Technology certification, and the other on information blocking. It's funny to me that this is known as the information blocking rule because really it's supposed to prevent information blocking. It's supposed to enable information sharing and access. So it's sort of the opposite of how we term it. But the statutory requirement was pretty narrow, and ONC in its release of the final rule went a step further than that. It requires all actors aligned or outlined in the rule, which importantly or interestingly include health information exchanges, to make electronic health information available to patients and to any entity of their choosing, including third-party applications available. The reason that this matters and the reason that it is so relevant to HIPAA is that this will likely dramatically increase the amount of information, health information that's flowing from the healthcare system to individuals and to their health apps. And thus, again, that means that that information will lose its HIPAA protections. So it's a sort of interesting tension between wanting to increase patient access, wanting to enable patients to exercise their rights of access and have ownership. I put that in quotes because that's a whole other bag of worms of who owns health data. But we want patients to have their own data. We want them to feel like a powerful, enabled member of their care team. We want them to be able to request that their doctors send information directly to their health apps. But as I just spent 10 slides talking about, it does mean that HIPAA then no longer applies. And so there's likely a commensurate amount of education that needs to go into explaining to patients that it's great that you want your data and it's great that you want it to be in this really cool app that you have, but please then note that the HIPAA protections no longer apply. The CMS rule is a little weedier and wonkier. I will not read all of this, but it involves standards-based APIs and disincentives for providers found to be engaged in information blocking. Again, I'm happy to answer CMS Final Rule questions at some other time, but when it comes to information blocking and patient access, so many of you had questions about, it's really the ONC rule that is a little bit more relevant to that. Then with respect to the HIPAA Notice of Proposed Rulemaking, again, this is, it was a long time coming. There was a request for information several years ago from the Office of Civil Rights within HHS that asked, how can the agency update the HIPAA privacy rule to make it easier to share PHI among healthcare providers, caregivers, care team members? There's really been a push in recent years across all elements of the healthcare system and the previous administration to increase information flow, to get data into the hands not only of the patients to whom it pertains, but to their caregivers and care teams. And this HIPAA NPRM is really focused on achieving that, of clarifying the existing HIPAA provisions, but facilitating delivery of better coordinated care, better value-based care. And the provisions, the proposed revisions really do their best to not only clarify the existing HIPAA rules and regulations, but expand the circumstances under which and the people to whom health information can be disclosed. During the pandemic, I will also say that I always hate to say that there are any silver linings to COVID. There are not very many, but the push to share information, the push to get health data held by the healthcare system into the hands of patients themselves, and the increased focus on health data privacy and health information sharing for public health purposes took on a fairly new, I would say, significance. So that was certainly a part of the context in which this NPRM was released. And it's sort of, in tandem with these interoperability and information blocking rules, also focused on expanding individual access to health data, making it easier for health information to be shared. So they also are sort of part and parcel of this more information sharing, more patient access to information. All of it is great. Again, all of it also brings up privacy concerns because HIPAA is kind of the only show in town. And when we take information out of the healthcare system, we lose all of our special HIPAA protections. The Notice of Proposed Rulemaking is long. I could have a 3.5-hour webinar about the NPRM, but I just wanted to pull out some of the key proposals. The first slide focuses on the access provisions of the NPRM. So the key proposals that are related to patient access focus on shortening covered entities' required response time when a patient requests access to health information to 15 days. we can have an offline discussion of whether or not 15 days is even reasonable. One might think that should be a lot shorter and a lot sooner, but it's better than it was. The NPRM would also strengthen the right to inspect health records in person. Often that is something that patients either don't know they have the right to do or is hindered in practice. And so the rule takes really an explicit stand on wanting to make that easier. There's some clarifications to how requests for PHI should be responded to. When you request your health information, there can also be a fee. And so this proposed rule specifies when that PHI that you request must be provided at no cost, and providing better price transparency when it comes to that. There are all sorts of horror stories about a patient requesting his or her record, and you think of that as being a couple pages. Often it can be hundreds, if not thousands of pages, and at a charge per page, that bill can actually be very high. And so that was an explicit intention of this rule, is to reduce that, or at the very least be more transparent about it. Also, identity verification has come up a lot recently. Again, I've been talking a lot about identity verification in the context of vaccines and vaccine passports or digital health credentials, but verifying the identity of a patient who requests access to his or her health information, or even more in a more complicated way, that a patient's representative or a healthcare representative or caregiver, the identity verification requirements are pretty stringent, and this rule does its best to reduce those. There are also a number of proposals related to disclosure. So again, the key intent of this rule was to expand the permissibility of disclosures of PHI. So one of the categories is disclosures that are in the best interest of those that are in a health emergency or experiencing a health crisis, including mental health or substance use, making it easier to share that information when we're in an emergency, or when that information really could immediately benefit a patient or those around him or her. Related to prevent harm or lessen the chance of harm. HIPAA is often a complicated set of rules to navigate in a situation where there's somebody that is thought to be at risk, either to themselves or others. And when can you disclose information? What rises to the level of one of those permitted disclosures under HIPAA without individual authorization? This NPRM would expand the circumstances under which unauthorized disclosures are permitted. Again, care coordination and expanding it and making it easier and making it better is a big push of the NPRM and the information blocking and interoperability rules. So the exception to the minimum necessary standard was altered in the NPRM to enable better and expanded care coordination. And then facilitating care provided by social and community services organizations or community-based organizations. This is really seen as an expansion of what constitutes the care team. So again, expanding the category of people to whom health information can be disclosed without authorization. And this is really taking note of the fact that increasingly individuals have a large number of people around them engaged in their care, and that should be able to have access to the health information without authorization, which can be quite burdensome, not just their doctors, but people who might work for a health organization that doesn't constitute a provider, being fit into this context of sort of TPO treatment-based disclosures without individual authorization. There's, as I said, a lot of other things in the NPRM. To me, the sort of most interesting bullet on this slide is that related to the notice of privacy practices. Anybody who's been to a doctor's office knows that you get shoved a lot of paperwork, you sign a bunch of things really quickly. One of them is a HIPAA authorization. One of them is the notice of that provider's privacy practices. It outlines in detail what the provider is going to do with your information, what it's not going to do with your information. And there has been a requirement that the covered entity, which is why you have to sign it, have a signed piece of paper and then retain that signed acknowledgement of the notice of privacy practices for years. And the paperwork, the administrative burden, the even lack of clarity on the part of the patient of what am I signing, that has been proposed to be removed, the written acknowledgement part for the notice of privacy practices. That has been strongly supported by the broader community. Again, some telecommunications relay services proposals, extension of permission to disclose PHI of armed forces personnel to the United States Public Health Service. All of these, as you can see, fitting into that umbrella category of easier exchange of information for care coordination purposes, and then elimination of some of the burdens associated with information sharing. Oh, COVID. I've been teasing those that I work with that not every single webinar and every single thing about health information has to have a COVID angle, but HIPAA actually does have a COVID angle, and a lot of you asked about telehealth. COVID was declared a public health emergency, and during that formally federally declared PHE, as the cool kids say, the Department of Health and Human Services relaxed its enforcement discretion with respect to telehealth. So what that means in practice is that the government wanted to make it easier for people who couldn't go places or see other people due to COVID to still receive healthcare. Unfortunately, we have this robust telehealth system that was strengthened a lot, but there are particular requirements under the privacy and the security rules as to how telehealth can be provided, who can provide it, what technology they can use. And there was a lot of anxiety at the beginning of the pandemic about around providers wanting to provide telehealth services, but being worried that they were not going to be able to do it in such a way that complied with HIPAA, either on the privacy rule or security rule front. And so HHS decided that it would relax, as I said, its enforcement authority for violations, and sort of more simply, it would not penalize or impose penalties for non-compliance with HIPAA against any provider when it was in the connection of good faith provision of telehealth during COVID. Some of you may have been involved in the efforts to advocate for this relaxation to remain in effect even after COVID. EHI is strongly supportive of that. I think what we've seen is that telehealth is essential. It is certainly saved us, or saved many of us, during the last year and a half, and relaxing the precise technical standards by which that provision of care to vulnerable, needy, rural, ill people or communities that may not have access to providers, as some of the rest of us do, is really essential to promoting and ensuring public health. There were also a lot of questions that came in at the registration about COVID vaccine passports. And I will shamelessly plug a webinar we did last month about vaccine passports and associated privacy issues. One of the first things I learned as part of that webinar is that we really shouldn't refer to them as vaccine passports, largely because that's such a controversial term that has become politicized and weaponized. Really, the issue is the use of digital health credentials. With respect to HIPAA, any application of HIPAA to vaccine information and status is, of course, dependent on whether or not the holder of that information is a covered entity. It's certainly PHI if it's vaccine status, and certainly if your provider gave you a COVID vaccine, that information is covered by HIPAA. But we've seen very often that the community push to vaccinate people means that there are a number of places and people who've held vaccine information that are not subject to HIPAA, even as they transmit that data to HIPAA covered entities or the government. We don't know exactly what's going to happen with respect to the United States, or I should say individual states' use of vaccine passports or digital health credentials for access. I can say that it would be a very different situation if a state or federal government was requiring the showing of proof of vaccination versus a private organization or entity. So for example, a stadium, a sports team has different flexibility when it comes to requiring proof of vaccination before entry than would, for example, a state. But I will just say that again is the subject of much debate, hours worth of discussion. You can check out that taped webinar and all of these issues that I mentioned, privacy, logistics, and others on the EHI website. And we have another webinar coming up on June 1st related to the challenges for providers with respect to identity verification when it comes to uploading and using patients' health information in vaccine credentials. All right, my favorite topic, and apparently one of your favorite topics, is what is next? As I said at the beginning, most of my job at EHI is focused on the health data that lives outside the traditional health system. I mentioned earlier in the webinar all of the various tech platforms that we all use every day that are holding health information. And this seems to be sort of the wave of the future. The wearables, the health and wellness apps, the health tech industry is expanding. The use of AI is expanding. And now that we have the information blocking and interoperability rules, all of the combination of which will just be pushing health information from the healthcare system to individuals. We have this large universe of health data that lies outside the HIPAA protections. What protects health data when it's not under HIPAA? I don't have any text on this, but notably, it's the Federal Trade Commission. When a company sets out its terms of service, those are the company's terms of services govern how they use or won't use your health data. And so when you download or when you use a wearable or an app or a website, as you're, I'm sure, familiar with, you have to click, you accept the terms of service. That doesn't really work that well in practice when it comes to protecting privacy. Most people don't read them. They probably, even if they did read them, wouldn't fully understand them. They're too long, the font is too small, and very often you just need what you want to download this thing for. And so you're going to say yes to whatever it is, as long as you can get it on your phone and get your information in it to use it. So again, that's not really a particularly effective way to protect privacy. And there's, again, an education component in all of this. I think very often people think, well, it's health data, so it's protected by HIPAA, and I don't really know anything about HIPAA, but I know that HIPAA is good and it protects my stuff. It doesn't here. There are some companies that do an excellent job and are very privacy forward and thinking very much about the sensitivity of health data in particular, but others aren't. All you need to do is pick up a newspaper to read about some application that sold or misused health data. And very often that health data is incredibly sensitive. There are a couple of case studies involving reproductive tracking apps, and you can just, I would not want my sex life and all of the details of my ovulation out there for many to see, but unfortunately that has happened. It did just a couple of months ago to much fanfare in the press. So shameless plug for my work at EHI. With our grant partner, the Center for Democracy and Technology, we spent the last year with funding from the Robert Wood Johnson Foundation putting forward developing a consumer privacy framework for health data. And that is designed to, in the absence of new federal privacy legislation, which I'll talk about next, shore up the protections for health data with the partnership of industry. There are a number of codes of conduct out there. There are lots of sets of best practices for how and what companies, how they should use and what they should do with respect to health data, but there's no accountability for that. They can say they'll do it, but again, as long as they don't violate their terms of service and are not caught, there really is no accountability. So again, I direct you to the EHI website. It's some really excellent bedtime reading. I think it's just as good as melatonin and a glass of red wine, but there's some great stuff in there. We had close to 60 partners from all across the healthcare industry on our steering committee. And the framework has both a set of health data use standards that actually go beyond HIPAA, or more restrictive than HIPAA, more protective than HIPAA, I would say, and an accompanying proposal for a self-regulatory program to hold companies accountable to those standards. That framework will hopefully at some point be less necessary, because it does seem like rather than overhauling and updating and continuing to tweak HIPAA, we're probably headed toward new comprehensive federal privacy legislation. I don't know when. If any of you know when, please tell me. We have had a number of conversations with members of the Hill and with various Senate and House committees that are working on this. There was an enormous amount of momentum for new privacy legislation maybe 2 years ago, and then we had the election, and then we had COVID, and so pretty much everything other than the election and COVID got deprived of oxygen for some time. But it does seem like momentum is picking up again. And as I said, rather than a lot of questions came in about like, how does HIPAA need to be updated and when is it going to be updated? Again, I think the NPRM is doing its best. The Notice of Proposed Rulemaking is doing its best to modernize it a little bit, to again, promote individual access and to promote care coordination and expanded health information sharing. But increasingly, legislation that is privacy focused is not necessarily just focused on health data, it's focused on personal data. So I will not pretend to be an expert on Europe's GDPR or even the newer state laws on this, but I can say that the wave of the future has come, and it is likely that, at least in some significant ways, any future US federal legislation will be modeled, again, in some or in part, on GDPR and California's consumer CCPA. I'm going to get the acronym wrong. And then really excitingly for those of us who are in Washington, and these are our neighbors in Virginia, Virginia just passed a Consumer Data Protection Act. So they became the second state to kind of follow Europe's lead in putting forward and approving this much more expansive data privacy legislation. Virginia's law doesn't go into effect for a couple more years. California's already is. Both of them are pretty controversial because while the intent is wonderful and everyone supports it, implementing them and going from having only HIPAA to a new data privacy law is hard on companies. So again, not to say that we let perfect be the enemy of the good. So in general, very supportive of these laws. I will throw another webinar and another big party, maybe to compare HIPAA, GDPR, California and Virginia, because I would say not half, but a lot of questions that you all had were about these laws. The big thing to know is that these laws are different from HIPAA in sort of two main ways. One is their purpose. Their purpose is to protect personal data, which is very broadly defined, not health data. So again, as I've just spent 45 minutes blabbering on about, HIPAA applies to only a very particular type of data held by particular people. European laws, the California laws, the Virginia law, those are designed to apply to a much, much, much broader scope of personal data. And they also cover a much broader scope of people. So it's not just providers and health insurers. It's really any entity that handles personal information. So as you can imagine, that could be almost anyone. And so again, without having a chart comparing these laws, note that HIPAA is not similar to them, but that likely if we are to be lucky enough to have our own GDPR or our own federal data privacy law, there will be many, many people employed for many years on figuring out how that law works with HIPAA. In some of these laws, there is a safe harbor for HIPAA, or HIPAA is referenced by extension. So it wouldn't be that there likely wouldn't be compliance contradictions. Rather, HIPAA would be sort of baked into compliance of the broader law. But they really serve different purposes and are really designed to protect different people. I think, oh my gosh, how do I go back? I think that's it, which shocks me and makes me nervous that I just talked very, very fast to all of you. But the good news is that we have 15 minutes for questions. And if you'll bear with me, I will look through these questions and see if there are any that I can answer on the fly. A question about whether patient reviews on a physician practice Facebook page are affected by the NPRM. I don't know the answer to that. So I will just flag that as something to follow up on. I'm trying to do a quick HIPAA analysis in my head. I'm not sure that a physician practice Facebook page, well, I don't know that I'm just going to skip that one because I'm about to talk and say things that may not be legally airtight. HIPAA and information blocking. There are some contradictions between HIPAA and the information blocking rules when it comes to timeframes for provision of access. That is something that a lot of comments on to the HIPAA NPRM focused on. They did their best to be aligned, and they were aligned in many ways in intent and purpose. But there are a couple of things when it comes to, again, really specific timeframes where there's a little bit of misalignment, and hopefully that will be fixed in the final rule process. Specific guidance and rules that explain the bullet: once data leaves a covered entity, the law and its protections no longer apply. Well, I did my best and probably said too many times about how when data is no longer held by a covered entity, it's no longer covered by HIPAA, because HIPAA only applies to covered entities. So, and when the data leaves a provider and goes to a person or an organization that is not a HIPAA covered entity, it loses HIPAA protections just because by virtue of the coverage of the law and the way that the law's coverage is defined. Does in writing include electronic means? Yes. Sorry, everybody. I'm sure this is not very interesting for you to watch me stumble my way through this tiny font. Does HIPAA covered data entered into patient portals or personal health records by a patient or consumer? No, patients are not on their own when it comes to protecting their information when communicating with the provider, because as soon as the provider has access to it or sees it or is transmitted to the provider, it gains HIPAA protection. So yes, PHR data just held by an individual is not covered by HIPAA, but if it's a patient portal with the provider, it is. All right, HIPAA covered entities. I will just refer you to earlier slides on those definitions. ONC Final Rule affect those offices that have patient charts. Oh yes, that has been a big topic of discussion. The rule is very detailed about not blocking access of information when the patient requests, but it's also really focused on these APIs, these third-party apps. And so there were a lot of physician comments about the increased or potential increased administrative burden on getting patient information from paper chart copied and disseminated. I don't know that there's really an answer to that, other than that it's certainly a topic of a lot of discussion in provider communities. Again, not the big modernized health systems, but a lot of smaller providers or providers in more rural areas that just are subject to the new rules, but may not have the ability to do it as seamlessly as others. I'll also note that there was, I don't want to say pushback, but there was some concern among providers that even when it comes to transmitting data as now required from an electronic health record system or from their own health systems, whichever they use, to a third-party app electronically, that's still not necessarily that easy. Again, shameless plug for the consumer framework, but how are the providers or patients to know which is the right app? Very often a patient will say to their provider, I want access to my health information. I don't know what to use. I don't know what app to use or which company is good. Can you tell me? And so we heard from a lot of providers about how, sure, they could do the research and figure out which nutrition app or even just personal health record app is the best, which is the most privacy protective, which is the most user friendly. But any of you providers on this call can know that the workload isn't small. You don't have a ton of time to just do some research on behalf of your patients. So one of the intents of the framework would be able to put together a list publicly and even visually on an app store that denotes those health tech companies that have subscribed or certified or tested to following these privacy standards, so that a provider could say, oh, in the Apple store, look for an app that has a blue star or a gold medal or whatever it might be, which would take a significant amount of the burden off the provider. Our framework can't help with the identity verification burden that I mentioned earlier, but a long way of saying that, yes, it is going to be challenging for paper records. It's also even going to be challenging when it comes to the most tech savvy companies out there. And that was certainly an area of a lot of discussion when the information blocking and interoperability rules were finalized. Will the slides be sent out and will there be a recording? Yes. I will make sure that these slides are posted after the presentation, and we are happy to send slides out, or you can just visit our website where both they and the recording will be posted. Watchdog app or organization where consumers can look up companies that do a better job at protecting data. Yes, when the framework is finalized and implemented. I'm sure there are, and I'm sure that if you spent some time on Google, you could find them. But again, it would probably take you longer than it should. And the intent of our project, really, our work really is to make it very easy for consumers to understand which companies are doing a better job with respect to protecting the privacy of their data. Again, there's sort of a baseline trust in providers, in payers, in the healthcare system that really doesn't exist within the consumer-focused health tech industry. Or even put a sort of darker way, there might be trust, but there shouldn't necessarily be that trust, because the privacy practices and the data use practices of so many of these health tech companies are very poorly understood. So I think it would be an enormous benefit to consumers to know that their health data is protected by HIPAA when it's in their doctor's office. And then when they choose to transmit it to some sort of app that they can be more involved with themselves, they can pick an app that is just as protective, if not more protective. And even if not understanding what those protections are, feel like transmitting the data from one category of actors to themselves and their technology that they pick doesn't bring with it an accompanying risk of more vulnerabilities to their data. All right, I could talk about public health registries and disease and lab reports via public health and HIPAA if I did 10 minutes of research on it. So I'm going to just skip that one because, again, I don't want to say anything that is wrong. I mentioned this about new comprehensive federal privacy legislation replacing versus complementing HIPAA. My hope and understanding is that the aim is that it would complement HIPAA. It likely won't replace HIPAA. I think the challenge will be finding a way to make the law broader and in some ways filling some of the gaps that come with HIPAA and state law coverage. And therefore complement it, as you ask, but not run afoul of it. And I don't mean to say run afoul in terms of intent or purpose, but there's so many, as we saw from the timeline issue that I was mentioning earlier with respect to the HIPAA, NPRM, and the information blocking rules. It's very hard to get every single little precise metric to align. And so my guess is that if and when we get a bill, we get a law, so much of the work ahead, especially when they're implementing regulations, will come with respect to aligning the particulars so that there isn't any conflict with HIPAA. And again, I no longer work at a law firm, but I know that the figuring out how to implement the California Consumer Protection Act has been incredibly complicated. It's not because of anything that's wrong with the law. It's just that to align CCPA with other California health regulations, to align it with HIPAA, to align it with some of the other federal laws governing health information, it's just complicated when you have a new and sweeping rule such as law such as the CCPA, and certainly when we have a new federal one. Security for logins and email and passwords. I'm not a security rule expert. I am happy to answer specific questions about that, but the security details are not in the HIPAA privacy rule. They're in the HIPAA security rule. They require a particular vocabulary and brain that I unfortunately don't have, but there's certainly answers to those questions to be found in the security rule. This is a good question that I maybe should have mentioned. There are limits of HIPAA with regard to data leaving the protection of HIPAA, but do other privacy laws come into play? Yes, sometimes. There are other federal laws that apply to health information that are not HIPAA. There is FERPA, which governs health information and educational records. There are the Part 2 regulations that I mentioned that cover substance abuse treatment disorders, or substance abuse disorders in their treatment. There are, let's see, many state laws. So again, it's not that the laws, or it's not that the information when it leaves the protection of HIPAA loses everything. It just loses HIPAA protection. So the corollary in the consumer space is the Federal Trade Commission Act. So that's why I mentioned FTC. Those companies that are subject to the FTC are also subject to Section 5 of the FTC Act, which prohibits unfair and deceptive trade practices. That's really the section under which companies get nailed when they violated their terms of service, done something with the data that they said they wouldn't, or not done something with the data that they said they would. So that's sort of the high level corollary of HIPAA in the healthcare system, FTC outside. But there's certainly ways that that the data that could be analyzed, that the data would be covered. I will say that most of this, if not all of the state laws, have the same sort of categories of actors of coverage that HIPAA does with respect to the healthcare system and providers and payers. But for example, there's some states that have particular protections or requirements and obligations that apply to acupuncturists or occupational therapists, and those differ by state. So again, depending on who holds the data, not just necessarily the individual with your phone, but depending on what's being done with that data and where it's going, it may well be subject to one of those bigger picture federal laws that I mentioned. Another one of them is the Common Rule, which governs research, federal subjects research, but more likely the analysis would be under state law. All right. Yes. Question about trying to get the COVID vaccine to homebound citizens, wondering whether people could send us their names and addresses so they could bring the vaccine to their doorstep. The information that they send is not considered protected health information until it reaches you, the healthcare provider, and the HIPAA covered entity. That is correct. If data is sent from a covered entity to a third party such that the data in the hands of the third party is not protected by HIPAA, does the covered entity still have to treat the data as protected? Well, that's an interesting question because then it gets into copies of health data. Yes, when a provider sends you a copy of your health information or a copy of your health information to a third-party app, the covered entity is most likely should be retaining a copy of that health information. If you ask your provider for a copy of your health record, they don't give you the physical record and lose it forever. So the copy of the information that's still in their control retains all of the same HIPAA protections. So it's not that information is losing its protection in that same healthcare setting, but it just means that once it gets to the third party or it gets to you or there are 2 or more copies of it, those copies don't have HIPAA protection. So that's one way of thinking of it, is that it stays safe when it's at your provider and it will always have that protection, but it's living other places. And that's why we talk about sort of increased and broadened risk exposure. All right. I'll answer one last question since we're 1 minute out, and I've really never been so bored of the sound of my voice. So I really want to thank all of you who stuck with us this long for your attendance. Business associate obligations outside of just entering into a business associate agreement, they are the same obligations as under HIPAA. Once you sign a business associate agreement, you are subject to HIPAA and all of its obligations and requirements, just as covered entities are under the law and its implementing regulations. So it's kind of, once you sign a business associate agreement, for all intents and purposes, you have the same obligations as a covered entity. You can think of yourself that way. And I think I got through all but about 2 of these questions. I'm so grateful for your engagement. I'm so grateful for your time. And again, feel free to follow up with anything I didn't hit. Slides will be on the website, so will the recording. And thank you all so much.